Retrospective research published in the Lancet's Historical Medicine Archive lays bare a deeply uncomfortable and erased historical truth. The figures hidden behind the iconic beaked masks were never selfless saviors. They were municipal contracted crisis laborers and corrupt opportunists, as well as enforcers of rigid class hierarchy. They turned mass death, widespread public panic, and medical helplessness into a tightly regulated, infinitely profitable industry. That industry further split European society along lines of wealth and authority. It rewrote municipal governance rules, eroded religious public trust, and built the foundational framework for the modern two-tier healthcare system. It also weaponized terror to cement elite privilege, while abandoning impoverished communities to unmonitored illness and neglect. The waxed canvas suit with glass eye lenses and herb-stuffed bird snout etched into global pop culture was not invented during the initial 1347 Black Death outbreak. That outbreak wiped out half of Europe's population. Municipal archival records confirm this standardized protective uniform was formally designed by physician Charles Delorme in 1619, more than 2 centuries after the first plague wave ravaged the continent. Most field practitioners responding to the original medieval pandemic only wore simple loose robes and cloth face coverings, with no standardized protective gear whatsoever. The later mythologized costume was crafted not merely to block miasma in the air, but to create an intimidating, otherworldly visual barrier. It separated these official medical agents from the general public, marking them as representatives of city authority rather than community caregivers. This deliberate visual divide was the first fracture that severed trust between plague doctors and the people they were theoretically tasked to protect. Long before any official plague doctor position existed within European city governments, medieval medical practice operated as a communal compact. Village healers, monastery physicians, and traveling herbalists offered low-cost or free treatment to peasant households during local disease outbreaks. They had no legal power to force quarantine, conduct mandatory body inspections, or dispose of the deceased against family wishes. The cascading collapse of social order brought on by the Black Death erased this informal medical safety net entirely. University-educated qualified physicians fled walled infected cities in droves to preserve their own lives and private estates. They left a vacuum where no recognized medical personnel would attend to dying commoners. Municipal councils faced mass decomposition of unburied corpses, uncontrolled contagion through cramped slum districts, and rioting public panic. The public demanded a visible force to manage the ongoing catastrophe. To resolve this administrative crisis, city administrations created the official role of contracted plague doctor. It was a paid civil service position with legally defined powers far exceeding ordinary village medicine. Payroll ledgers preserved in Orvieto, Italy, document that the city government paid its appointed plague doctor, Matteo Fu Angelo, 4 times the annual salary of a senior practicing physician in peacetime. These exorbitant base wages were funded entirely by public tax revenue levied on all residents regardless of social class. Yet the contractual obligations written into every official plague doctor employment agreement contained a hidden loophole that upended the entire purpose of public medical service. Binding municipal contracts only required these practitioners to record fatalities, oversee mass grave interment, enforce household lockdown orders, and conduct basic symptom checks for low-income neighborhoods. There was no mandatory clause compelling them to administer consistent treatment to impoverished patients. Wealthy households were permitted to negotiate separate private payment arrangements for exclusive home visits and personalized remedies, as well as priority isolation placement outside overcrowded public pest houses. This built-in contractual inequality birthed the world's first legally sanctioned 2-tier emergency medical system. Access to survival care was tied directly to the ability to pay supplementary fees on top of taxpayer-funded base salary. Plague doctors quickly realized they held an absolute monopoly over all formal interaction with the sick and the dead within plague-stricken towns. They weaponized this monopoly to layer endless predatory surcharges onto every core task they performed. They demanded extra silver coins to seal burial coffins, issue official death certificates required for inheritance claims, witness will signatures for terminally ill landowners, escort grieving families to designated cemetery plots, and mark abandoned homes as safe for reoccupation after a resident had perished inside. CDC archival research on medieval epidemic economic patterns notes that many plague doctors accumulated enough personal wealth within a single plague season to purchase manorial land and hereditary social status. They climbed from marginalized itinerant laborers to landed gentry by capitalizing on collective grief and fear. Beyond direct monetary extortion, plague doctors served as armed enforcers for authoritarian public health policy. That policy disproportionately punished the poor while granting exemptions to aristocratic and merchant elites. City ordinances empowered these masked officials to enter any residential dwelling without a warrant and inspect for plague symptoms. They could nail wooden planks across doorways and windows, locking entire families inside contaminated homes with no access to food or clean water. They could separate sick children from guardians and relocate them to remote isolation camps with zero oversight. They could report any citizen attempting to flee a quarantine district to town, watch forces for arrest and heavy fines. Elite families with political connections or financial means could submit formal petitions to municipal health boards. They received written exemption documents that barred plague doctors from entering their private villas or country retreats during lockdown periods. Venice port quarantine logs preserved in the city-state's National Archives show that plague doctors stationed at waterfront entry points regularly accepted bribes. They overlooked fever symptoms and allowed wealthy travelers and cargo ships to bypass mandatory 40-day isolation protocols. Meanwhile, migrant laborers and homeless wanderers were detained indefinitely at quarantine stations, with no access to food or release options, even with mild non-plague fevers. This selective enforcement did not stem solely from individual cruelty. It was baked into the core mandate of the plague doctor institution. That institution existed first to prevent contagion from spreading into wealthy commercial zones and noble residential quarters. Only second did it manage the humanitarian crisis spilling out from overpopulated working-class slums. Religious authority also suffered irreversible erosion at the hands of plague doctor institutional power. For generations, the Catholic Church held exclusive rights to perform last rites, consecrate burial ground, and validate spiritual funerary rituals for the deceased. As clergy mortality surged and parishes lost most ordained priests to plague infection, city governments transferred legal jurisdiction over corpse handling and death documentation entirely to contracted plague doctors. These officials often refused to allow church priests to administer final sacraments to dying patients unless the parish paid a secondary administrative fee. They merged secular bureaucratic control over death with financial profit. Devout laypeople watched as sacred spiritual passages became subject to bureaucratic red tape and monetary negotiation. This deepened widespread disillusionment with both church governance and municipal authority amid unending mass death. Plague doctors also became central figures in state-sponsored scapegoating campaigns. These campaigns were designed to redirect public rage away from failed city planning, inadequate sanitation infrastructure, and elite abandonment of public duty. When civilian crowds grew restless over rising death tolls and the lack of meaningful treatment options, municipal leaders ordered plague doctors to compile formal written accusations against marginalized minority groups. The most prominent targets were Jewish communities residing within European town borders. The masked practitioners conducted forced house searches under official orders to plant false evidence of well poisoning or cursed plague artifacts. Then they submitted sworn testimony to local courts, justifying mass arrests and property seizure, punitive taxation, and public execution of accused groups. Trial transcripts from Basel and Strasbourg reveal that plague doctors received a percentage of all seized property from persecuted households. This was additional compensation for their testimonial work, turning systemic prejudice into another stream of crisis income for these state-contracted medical agents. A definitive real-world case study from the 1665 Great Plague of London lays bare how plague doctor systems prioritized elite stability over mass human survival. The city council hired a rotating team of contracted plague physicians tasked with canvassing every parish. They marked infected households with red-painted crosses and enforced total internal lockdown. Official city records show that plague doctors were instructed to deliver weekly food rations only to households headed by guildmasters and landed property owners trapped under quarantine. Working-class families locked inside cramped tenement buildings received no government provisions whatsoever. Dozens of contemporary personal diaries from London's East End document that plague doctors would refuse to unlock front doors, even when children inside the home starved to death. Yet they would immediately remove quarantine markings for upper-class households upon receipt of a private gratuity. Many London plague doctors abandoned their official posts entirely once wealthier neighborhoods began to empty as nobles fled the capital for rural estates. They left the poorest parishes with no official medical oversight or corpse removal services until mass burial carts were deployed by emergency municipal crews weeks later. This abandonment exposed that the plague doctor role was never designed as a permanent public health safeguard for all citizens. It was only a temporary administrative tool to contain visible unrest, so elite power structures could remain intact throughout the epidemic. Contrary to popular modern myth, plague doctors possessed no scientifically effective treatment for Yersinia pestis infection. Their prescribed interventions centered on the ancient humoral theory of medicine. These included aggressive bloodletting, purgative herbal mixtures, skin-blistering poultices, and repeated exposure to strong vinegar fumes. None of these methods reduced mortality rates or halted disease progression. A comparative epidemiological study published in The Lancet confirms that patients receiving formal treatment from contracted plague doctors had nearly identical fatality rates to those receiving no medical intervention at all. The only measurable public health advancement originating from their widespread deployment was the formal codification of household quarantine, centralized mortality record-keeping, and standardized corpse disposal protocols. These critical pillars of modern public health were not created out of humanitarian compassion. They were created from a need to systematize and tax the process of dying within a city under state administration. Plague doctor bureaucracies evolved directly into the first permanent municipal health departments across Italy, France, and England. They created a precedent where public health policy is first structured to protect economic trade and ruling class safety. Only afterward did it address the health needs of marginalized low-income populations. The enduring cultural myth of the heroic plague doctor emerged centuries after the Black Death receded. Engravers and storytellers romanticized the beaked costume into a symbol of selfless sacrifice. They stripped away the historical layers of class enforcement, corrupt fee-taking, selective policy enforcement, and complicity in state persecution that defined the actual job function. Modern public health crises repeatedly mirror this forgotten structural dynamic. Official frontline medical and administrative workers are tasked with enforcing public safety measures that carry unequal burdens for low-income and racialized communities. Crisis response systems allow privileged groups to access private care and isolation options unavailable to the general public. Bureaucratic oversight of illness and death creates opportunities for predatory pricing and institutional profit during collective trauma. Governing bodies divert public frustration toward scapegoated groups, rather than acknowledging structural failures in urban planning and resource distribution or in crisis preparedness. This erased chapter of plague doctor history delivers an unavoidable lesson. Any formal emergency medical or public health institution will inevitably replicate hierarchy and exploitation unless its core mandate is legally bound to equal care for all people, regardless of wealth, residence, or social standing. The mask of public service can easily hide systems designed to profit from suffering and reinforce pre-existing societal cracks that a pandemic only magnifies rather than creates. If you wish to explore more misrepresented historical figures and hidden power structures buried within epidemic social history, leave your preferred historical topic in the comment section below. These topics could include how wartime medical personnel shaped class divides during the Spanish flu, how colonial quarantine officers weaponized disease control for territorial control, or how modern emergency healthcare inherited medieval two-tier treatment systems. Subscribe to the Epidemic Archive channel for rigorous source-backed deep dives into how disease reshapes politics, class struggle, and cultural memory across human history. And share this video to dismantle the long-standing myth framing plague doctors as uncomplicated heroic icons. reveal the institutional inequality hidden beneath one of history's most recognizable medieval symbols.